Welcome to the deep dive. Our job is to take vast, specialized knowledge, cut through the noise, and hand you the synthesized understanding you need.
And today we are tackling a really critical topic.
We're doing a deep dive into the absolute state-of-the-art of breast cancer radiation therapy.
Yeah, and if you look at the literature for breast RT, it's not just big, it's fragmented.
Fragmented how?
You've got data coming from radiation oncologists focused on clinical outcomes. Then you have medical physicists modeling beams and dosimetrists just focused on planning.
And that can lead to knowledge gaps.
It can, and sometimes, outright misconceptions about what modern quality breast care actually involves.
So our goal for you, the learner, is to merge that clinical evidence, the hard physics, and the operational expertise into one harmonized view.
We're essentially building a blueprint for best practice, starting right at the very beginning with the infrastructure itself.
Okay, let's unpack this.
So the absolute foundation of high-quality patient care is fundamentally organizational.
It's the system.
Exactly. The European Society of Breast Cancer Specialists, USOMA, and the ERQCC are very explicit here.
And what's their mandate?
Modern breast cancer treatment must happen in a specialized breast center. It's not just a clinic. It's a comprehensive hub.
Offering everything from, genetics to palliative care?
Everything. Genetic testing, prevention, all the way through to supportive care, palliation, and cyto-oncology.
And it's not just about the services they offer. The sources really stress the importance of scale.
Oh, absolutely. To maintain that high level of expertise, to keep skills sharp, a certified center needs to manage at least 150 new cases of early breast cancer.
150.
And a minimum of 50 metastatic cases every single year.
And that volume is what keeps the team sharp.
That's the idea. If your team isn't seeing enough complex cases, they might fall back on older, maybe less optimal approaches. That caseload ensures the entire multidisciplinary team, the MDT, stays proficient.
Speaking of the MDT, we all know the core specialists.
Yeah.
The surgeons, oncologists, pathologists.
Right, but the mandate also specifies that all new diagnoses and any major change in a treatment plan must be discussed at a dedicated multidisciplinary meeting, the MDM.
And this is where that patient-centered care really comes into focus.
It is, because it's not just about the core team. It emphasizes consulting supplementary specialists when they're needed.
Like who?
So you might bring in a geriatric oncologist for an older patient, a psycho-oncologist for severe distress, or a clinical geneticist. It moves the discussion beyond just the tumor biology.
To genuine human complexity.
Precisely.
Yeah.
And that high standard, it requires continuous learning.
Right. The material details that modern training for, say, radiation oncology trainees has to shift its focus.
It's no longer just about time served.
It's about demonstrated explicit competencies, often guided by frameworks like CAN-NDs. This means training is much more than just reading a textbook, right?
Oh, absolutely. The workplace-based training has to expose the trainee to the entire case mix, from early stage to terminal care.
And you mentioned it covers two different skill sets.
It does. First, you have the technical skills mastering things like target contouring, physics planning. But then there are the soft skills, which are, honestly, often the hardest to teach.
Like leading an MDM discussion.
Exactly that. Or communicating complex risks, having those really difficult conversations with patients and their families.
And to teach these sensitive skills without risk, the sources highlight some specific tools.
They do. Simulation-based training is a big one. They mention platforms like VMAT, which uses virtual reality.
Or even just simple role-playing exercises that are recorded.
Right, with audiovisual equipment. The whole point is allowing trainees to make mistakes safely in a controlled setting. It's invaluable.
Which leads directly to another concept, error-based learning.
Yes, which is vital in any technical field. Imagine a trainee looks at a treatment plan and doesn't see that the isodose plot.
Those are the lines showing the dose distribution.
Exactly. And let's say there's an inappropriate hotspot right near the heart. If they can't spot that error, it means they don't fundamentally get the core physics concepts.
Like what are they missing?
They might not grasp how a standard beam behaves, the depth dose curve, or how we manipulate that dose with tools like wedges or the field within field concept.
Which is a planning technique to smooth things out.
Right. You have to understand the fundamental physics to recognize when the computer gives you an answer that's clinically dangerous. This is where physics and biology really meet.
All right, let's shift from the team structure to the actual delivery of the radiation. We know breast RT has an incredibly narrow therapeutic window.
It's very narrow. Small changes in setup can have significant clinical consequences.
So what are the key setup details that keep us on the safe side of that window?
It all starts with the simulation process. The standard positioning is supine, so lie on the back on an inclined breastboard.
Arms up and away?
Arms abducted, yes. And we use immobilization devices to make sure that position is accurate and reproducible day after day. Reproducibility is the silent hero of quality radiation.
But the sources also introduce a variation on this. Prone positioning. When and why would we flip the patient over?
Prone positioning is usually for patients with larger or more pendulous breasts who are getting breast-only radiation. The advantages are purely dosimetric, and they're quite clever.
How so?
When the patient lies on their front, the breast tissue naturally falls forward, away from the chest wall.
Which would eliminate skin folds, I imagine.
It eliminates skin folds, it narrows the breast shape for a more homogeneous dose, and critically, it significantly reduces the dose to the heart and lungs. They're just further away.
That's such a simple mechanical fix with a huge clinical benefit. Speaking of which, let's talk about deep inspiration breath hold, or DIBH.
DIBH is becoming standard, and for left-sided treatments, it really should be unless it's contraindicated.
What's the mechanism? How does it work?
It's a very effective form of respiratory control. When the patient takes a deep breath and holds it, the diaphragm moves down.
Pushing the heart with it.
It physically displaces the heart inferiorly, medially, and posteriorly. You're literally pushing the heart out of the way of the high-dose radiation. It's a critical step in reducing the risk of late cardiac toxicity.
So now we have the patient perfectly positioned. We need to define the target volume, or what you call delineation, and that means knowing exactly where the tumor was.
And that is often impossible without really strong communication with the surgical team.
Because of new surgical techniques.
Yes, surgeons are increasingly using oncoplastic tissue rearrangement, which dramatically changes the anatomy after surgery. Without radiologic markers left in the surgical bed, identifying that precise area can be nearly impossible.
So we have to rely on established rules to draw those lines consistently. Can you walk us through the estro guidelines for this? For example, why do we care about a 5mm crop from the skin?
Okay, so standardization, like the estro guidelines, is mandatory to prevent us from missing the target or causing unnecessary toxicity. Let's take two quick examples.
Go ahead.
First, the CTVP breast. That's the target volume for the partial breast. It must be generous enough to contain all the glandular tissue. That's the tissue at risk.
Makes sense.
Second, for a post-mastectomy patient, the CTV parathoracic wall, the chest wall target, is restricted to the front surface of the pectoralis major muscle and the chest wall itself.
And that 5mm crop.
We crop 5mm from the skin surface, assuming it's non-invasive disease. We do this for two reasons. One, to spare the skin from too much dose, unless the skin itself is involved.
And two.
And two, because standard photon beams have a dose buildup region just under the surface. The dose actually falls off in the first few millimeters. We use that physical property to our advantage to minimize skin reactions.
Let's move into the clinical decisions then. Everything hinges on individualized risk assessment.
It does. Tumor characteristic size, grade, receptive status are obviously key, but the sources point out that our standard risk prediction tools have limitations.
In what way?
Well, tools like the RW risk calculator are useful, but they're often based on historical data. They don't fully account for how effective our new systemic therapies are today.
And they miss a human element.
They frequently fail to incorporate those critical patient-specific variables we talked about: fitness, frailty, comorbidities, and especially compliance issues.
This is where we can bring in the example from the source material. Let's talk about Mrs. X.
Mrs. X is a perfect case study. She had low-risk breast cancer, which usually benefits strongly from RT. However, she was a continued smoker.
So for her, the benefit of radiation for local control has to be weighed against another risk.
Exactly. It has to be weighed against her baseline, already substantial, risk of developing a second primary lung cancer. If we irradiate her chest, we increase that lung risk.
So for a heavy smoker, that increase in risk might actually outweigh the benefit of local control?
It might. And that requires a truly shared decision-making process. You're balancing two very different survival outcomes.
A difficult conversation.
A very difficult conversation. The team has to clearly communicate this risk-benefit calculation. Our priority becomes promoting smoking cessation just as much as it is making the RT decision. That's holistic care.
Okay, let's pivot to the evidence that drives our dose choices. We've seen a huge shift from conventional fractionation to what's called moderate hypofractionation.
It's been revolutionary, and the primary evidence comes from major trials like START-B.
And what did they show?
They overwhelmingly support these moderate hypofractionation schedules, things like 40 gray in 15 fractions or 42.5 in 16.
And the outcomes.
The local tumor control and the late normal tissue effects were comparable, and in many cases superior to the old standard of 50 gray in 25 fractions.
And this whole shift is rooted in radiobiology. There's a specific number that justifies giving larger doses per day, isn't there?
There is. We focus on the derived alpha-beta estimate for local tumor control, which the START trials calculated to be around 3.5 gray.
And why is that number so important?
Because it's low. It means breast cancer cells are highly sensitive to the size of the individual dose fraction. So using larger fraction sizes is actually biologically better for cancer cell killing while sparing the normal tissues. That finding is the justification for the entire movement.
Now, hypofractionation reduces treatment time, but what about complexity? When you need to cover regional lymph nodes, like the internal mammary nodes, the geometry gets much harder.
It does. And for that, we often turn to sophisticated approaches like hybrid VMAT.
VM is volumetric modulated arc therapy.
Right. And the hybrid part means we combine two standard tangential fields, which treat the bread, with arcs of radiation to cover those tricky nodal regions. It's essential for getting good coverage in complex cases.
And for the lowest risk patients, we can go in the opposite direction and radically simplify things with partial breast radiation.
Exactly. PBI, or APBI, is a huge advance in convenience. It's an evidence-based approach that targets only the tumor bed.
Which shrinks the target volume and treatment duration.
Massively. We're talking maybe 26 gray in just 5 fractions over a single wink. It's a huge reduction in burden for the patient, and it drastically reduces the dose to the heart and lungs.
Let's switch gears to the patient experience and talk about toxicity. What's the most immediate and common side effect they'll face?
That would be radiation dermatitis. It affects up to 90% of patients at different levels of severity.
And what are the key clinical recommendations for managing or preventing it?
Well, despite all the creams and lotions out there, the recommendations from organizations like MASCC are surprisingly strict.
And they say?
Topical corticosteroids, specifically mometasone furoate, are currently the only prophylactic treatment recommended based on strong evidence.
What about using a skin bolus?
That's a great point. Using a skin bolus during post-mastectomy RT is often debated. It's used to make sure the skin gets enough dose, but its use is also linked to a higher risk of severe skin toxicity because it maximizes the dose right at the surface.
Looking long-term, quality of life, or QL, is paramount. How do we move beyond just anecdotes and systematically track those outcomes?
By implementing patient-reported outcome measures, or PROMs.
It's like questionnaires.
Right. Tools like the distress thermometer or the QLQ-C30 questionnaire, they allow us to systematically monitor symptoms and track quality of life. This is proven to improve symptom management and can even help us reduce unnecessary clinic visits.
And what about other major late effects you monitor for?
We have to be vigilant about arm and shoulder morbidity. This loops right back to the quality of our delineation.
To avoid irradiating the arm or the nerves.
Exactly. You want to avoid the brachial plexus. Brachial plexopathy is a rare but debilitating complication. For lymphedema, we use the ISL staging system. And for fatigue, which is very common, NCCN guidelines point to non-pharmacological interventions first.
Things like activity enhancement and psychosocial support.
Before you even think about medications.
Finally, let's look to the future. Particle beam therapy, which usually means proton therapy, where does this advanced, expensive technology fit in?
PBT has a very specific niche because of its dose profile. Its availability is limited, but that steep dose fall-off makes it potentially necessary for a very small subgroup of women.
Who are these patients?
Typically, patients with high-risk features who need treatment of the internal mammary nodes, the IMNs. These are cases where even the best photon techniques, like VMAT with DIBH, still can't cover the target without hitting the heart with an unacceptable dose.
So protons can hit the target and miss the heart.
The sharp drop-off lets you meet both the target coverage goals and the strict normal tissue constraints. It solves a very specific geometric problem.
And whether this dosimetric benefit actually translates into better patient health is being tested right now.
It is. The ongoing Red Handing P trial is aiming to provide that level I evidence. It's specifically looking for a reduction in major cardiac events at 10 years for patients getting PBT versus high-quality photon therapy when those tricky IMNs are in the field.
So for you, the learner, the critical takeaway here is that breast cancer RT is not a static field.
Not at all. It's moving rapidly toward highly individualized treatment based on strong multidisciplinary collaboration, meticulous quality assurance, and a really sophisticated understanding of both radiobiology and patient anatomy.
So what does this all mean? It means the standard of care requires prioritizing not just the tumor, but the entire human being attached to it. Before we wrap up, we have a review question for you.
We do. We discussed the USOMA requirements for a specialized breast center. So thinking about our case, Mrs. X and her smoking, what are the 4 non-logistic, patient-specific factors that the USOMA mandate forces you to prioritize in her treatment planning process?
Think about that for a moment.
The key is that the MDM must formally prioritize the patient's own aims and expectations, their overall fitness, frailty, and cognition, their likely compliance with the treatment, and finally, the strength of their social and familial network. All 4 are non-negotiable parts of the decision.
That brings us to our final provocative thought. While techniques like VMAT and these hybrid methods give us that superior dose shaping we want,
Making the target dose extremely conformal.
they can also lead to something called a low-dose bath.
And that's the central tension in modern RT. These complex techniques expose a larger overall volume of surrounding normal organs, like the esophagus or the other breast, to very low but very widespread doses of radiation.
So you gain local control, you spare the heart.
But the integral dose to the rest of the chest goes up. And the long-term effects of that, specifically the potential for second cancers years down the line from this widespread low-dose exposure, are still not fully understood. It's the critical trade-off that defines modern treatment planning.